Hi, this is Josh Meyer coming to you from GI ASCO 2026. I'm a radiation oncologist from Fox Chase Cancer Center, and today we're going to be talking about non-operative management of gastroesophageal cancer, specifically esophageal adenocarcinoma that has a clinical complete response. So we know that chemoradiation can produce a clinical complete response and a pathological complete response in patients who are treated with the cross regimen. In particular, these patients were given carboplatin and paclitaxel and 41.4 gray radiation. And in that study, we know that there was a 29% overall pathologic complete response rate and a 23% rate in adenocarcinoma patients. These patients do very well with surgery, but the question is, do they really need the esophagectomy that they receive? We know that esophagectomy is a high-risk procedure with approximately a 50% significant morbidity rate, including things like reoperation, anastomotic leak, pneumonia, and reintubation. And we also know that these patients are at risk for a 9% 90-day mortality rate. This is even at high volume centers where maybe that rate goes down to approximately 6%. So this is a significant issue. We know also that these patients have a pretty significantly decreased quality of life after esophagectomy, and that this quality of life can impact things like swallowing, eating, and also things like dumping syndrome and significant weight loss. So for all of these reasons, it seems like a good idea to think about, is there a way to avoid esophagectomy in patients who may not need it? It's difficult to determine which patients who have a clinical complete response actually have a pathologic complete response. But there have been improvements in assessing this. So one significant improvement is the advent of bite-on-bite biopsies. Bite-on-bite biopsy is simply a second deeper tissue sample at the site of an initial biopsy in an EGD. And with this bite-on-bite biopsy, we have been able to see an increase in the detection of residual cancer in the esophagus with approximately 81% diagnostic yield with a bite-on-bite or second biopsy. We also know that this is a safe procedure. A large study was done recently and found a 0.2% rate of grade 3 or higher complications with this bite-on-bite biopsy technique. So this is a reasonably good test to tell us whether there is residual cancer in the esophagus. Not a perfect test, but a reasonably good test. The major study that was published earlier this year is called the SANO study, Surgery as Needed for Esophageal Cancer. And what that study did was take patients who were treated with the cross regimen, so carboplatin, paclitaxel, and 41.4 gray radiation, and assess all patients after that treatment, and then assign patients to either surgery or active surveillance. So there was a 35% rate of complete response in these patients, and those patients were then put on study. And in the active surveillance arm, 35% of these patients ended up with a clinical complete response that was sustained. There was approximately a 48% rate of patients who had local regrowth, and 86% of those patients ended up getting a salvage surgery. And then some of those patients also had distant metastasis. But very importantly, the operative complications were the same in both arms with an 82 to 84% rate of complications. And the operative mortality was 4 and 5% in the two arms, suggesting that this is a very safe thing to do. Additionally, overall survival and disease-free survival were identical in the two arms. So I think this is a good study to keep in mind, and it's a good option for patients to think about. It's really important to have shared decision-making with your patients to discuss things like active surveillance when you're assessing patients with a clinical complete response for esophageal adenocarcinoma.